So Gene is a physician anthropologist in the division of. He was a fellow in the division of infectious disease and geographic medicine at Stanford. He's now an assistant professor in the Department of Global Health and Social Medicine here at Harvard Medical School. And Gene's been working for a number of years in West Africa on Ebola. So he's going to present to us the case of Ebola, and then we will have a couple of responses after that. So go ahead, Gene.
All right, so thanks for the introduction and thanks for inviting me. So since the chapter itself won't take a half hour, I'll start out with a quick introduction to Ebola virus disease and our role in West Africa and what we've been doing for the last couple years. So for the outbreak, we were based in Sierra Leone. Here's Sierra Leone by chiefdom. I'm just going to race through this. Size of South Carolina, 6 million people. Very rich country, but not rich people there. Was established as a repatriation colony for former slaves in 1787, gained independence from Britain in 1961, and then many of you know about the Civil War from 11 years starting in 1991. Life expectancy is 46 years, maternal mortality, one of the worst in the world. TB incidence, so we've been talking a lot about TB, it's kind of there in the middle, and then literacy rates, one of the worst in the world at 43%. So Ebola, here's a colored electron micrograph. It's a filovirus, and there's 5 species. So the Zaire strain was the one circulating in West Africa. It was discovered in 1976. There's been more than 25 outbreaks since then, and it's named after a river in northwest DRC. And when we say that there were 25 outbreaks since, there were also outbreaks in West Africa before this recent one. People tend to report this as the first time it's there, but now that they've gone back and looked at samples from people that were frozen from 2006, 2007, even earlier, they're finding that people were already positive, so there were mini outbreaks even before this big one. So Ebola virus is a disease, is a zoonosis, and the event where it goes from animal population to humans called spillover, presumptively circulates in fruit bats and then can get transferred to non-human primates, and it decimates populations of those like it does humans. We'll talk about this in a bit, about how it was a lot of the reports in the news of the funerary rituals which were responsible for the spread, and then it gets into the cities and is amplified in health centers. So when you land at the airport and all around the country, here's the sign telling you to go to the nearest health facility. Once they realized that was the wrong approach, they started changing the posters to calling this 117. And so the case definition: fever and a contact with a suspected case, contact and any of these symptoms, or fever and any of those 3 symptoms, or unexplained bleeding. Here's case management, which was rarely used. As we'll get into, isolation was really the main focus of containment. So here's what happens when you call 117. The call goes to a office in Freetown where all these operators are. The operators take the details, then call the information out to the District Ebola Response Center. So this is an example of one. All 14, well, not all 14, all the districts that are affected by Ebola had one. And these were set up at least in Sierra Leone, in cooperation with the British military, who basically sent their logistics units. So the people that, if they were going to go invade Afghanistan, they're the ones that hang out in back and do all the supply chains and the radar and et cetera. So those guys came and set up different stations and whiteboards and laptops and all of that. So the call comes in, it goes to the alerts desk. The alert desk will send out somebody to verify in whatever village if the person meets case criteria. If he does, then, or she does, they send out the ambulance. Ambulance arrives, they get in their PPE, personal protective equipment, and then take the patient to an Ebola treatment facility for testing and once in a while treatment. Safe and dignified burials were an important part of the containment response. Each ETU had their own large graveyard. Here we are doing some of these village sweeps that you might have heard about, and the one in Liberia where they basically just cordoned off West Point and then like shot at people that left. Ours was very different. We basically just went door to door checking for fever. So Partners in Health came in, and this is what the centralized response looks like. And we had a big ETU, which I'll get into the chapter, but we also promoted this decentralized response where we built these small 12-bed units all throughout the region. The idea being that better for people to be treated closer to home, to be able to serve as a base for sensitizing campaigns, telling people about what was going on with the outbreak and what the symptoms were, and hiring local people to staff these things. So community care centers, that's what they look like being built. There they are at night. And then here we are, did a lot of training. So, we ran out of healthcare workers, so we went to the nursing schools and got all our CCCs were staffed by second-year nursing students who we taught to use PPE with the help of the World Health Organization. And this also happens to be the translator into Japanese of Haiti after the earthquake. It was interesting to run into him out there. And so each of these was staffed with those nurses and then 2 PIH clinicians, and then talking about the UN system. It's not unlike the system of chiefs. We basically had to do ribbon cutting ceremonies at these places. This one I did 4 times. Once for this chief, once for UNICEF, once for the president's wife. She's up here somewhere. And then here's UNICEF peoples. And I think some member of parliament. Here's what you got when you returned. You got a phone, you land in Atlanta, they give you a phone and they call you, for 21 days to monitor whether you have fever or not. This little package that you got every time you arrive costs more than the per capita spending on health care in Sierra Leone. 19? 19, so that's 19 humans worth of healthcare. And so yeah, we'd always collect them and then bring them back and give them to people. But so there's an article we wrote about the political economy of the outbreak, and we'll get into that. So let's.
I'm just curious, not to interrupt. Have you already shown what that vast Mordor style pit is?
No. Oh yeah, I kind of skipped over it really quick. That Mordor pit was. This is a kimberlite mine in Kono district, so it was like right around the corner from our CCCs. And I don't know if some of you seen that movie Blood Diamonds. Community care center, the small Ebola treatment facilities, which did actually give treatment. We'll get to. You've seen the movie Blood Diamonds. It's about this district, although it was filmed in Mozambique. It's essentially about this area where, the main point of that paper I was talking about are essentially, billions of dollars have come out of here, and there is zero to show around it as far as, roads, hospitals, education, schools, and so, distal causes, which I think the next presentation will get into of the outbreak, but are summed up nicely by this photo. All right. So, the title of this paper or report is The Pacification of the Primitive Tribes of Lake Geneva. Now, this fail better thing that we were talking about yesterday, do any of you know who this is?
Stan the man.
Stan Wawrinka, who has a tattoo of Samuel Beckett's. It's from one of Samuel Beckett's plays, so Irish Nobel Prize winning. He wrote Waiting for Godot, and it says, "Ever failed, no matter, try again, fail better." So the fail better is actually Nobel Prize winning literature, so we don't have to. Anyway, and he's got a tattoo to his arm. All right, so actually, yeah, let's go to this one first. I'm going to read very quickly a commentary we wrote, and it's almost like a postmodern commentary because we have the commentary in Lancet Global Health, then there's the author's then there's the letters to the editor, and then there's the author's reply. And they really all together make for a nice paper, and so I think this is the future of collaboration. You want to write with somebody, just write something that they don't like, and then they'll give you input, and you can put them all together into a nice paper. And so this will give you a background on sort of where this chapter comes from, in the sense that my soapbox these days is on symbolic violence, and essentially, Roger was talking about this yesterday. The terms we use, what kind of weight do they carry, what kind of work do they do, and in many cases, what kind of violence do they perform. So right here, we wrote this cheeky thing called the Ebola suspects dilemma. And it goes like this. In 1950, Merrill Flood and Melvin Drescher of the Rand Corporation developed a theoretical model of cooperation and conflict, which was later formalized by Albert Tucker as the prisoner's dilemma. The model represents a situation in which two prisoners each have the option to confess or not, but their sentencing outcomes depend crucially on the simultaneous choice of the other. Fittingly has become a paradigmatic example of individual versus group rationality, and is often used heuristic when conveying introductory social theory to students. And so although not a homologous predicament, the Ebola virus suspect also faces a consequential dilemma, and it's summed up here. So the rational, that is not informed by superstition or baseless rumor, aversion to West Africa's ill-equipped and poorly sanitized hospitals was described even before the 2014-16 Ebola outbreak. This characterization could a fortiori be extended to those Ebola virus disease suspects who eschewed presentation to an Ebola treatment unit, especially those units that offered little in the way of aggressive intravenous resuscitation. So consider the situation in which you are an Ebola virus disease suspect, that is, the case definition we talked about earlier. You had contact with somebody that had Ebola, and you have a fever. So, but you don't know whether you have the disease. So if you have undiagnosed malaria and stay at home, your chance of dying is 0.2%. So here's like your little decision tree. If you have undiagnosed malaria and go to an Ebola treatment unit, your chance of dying from Ebola virus disease is 16%. So we got that here. And we basically calculated that in the worst of settings, you would have a 25% chance of catching Ebola either in the ambulance ride there or at the place if you didn't already have it, because the infection and prevention control measures were so bad. So you have a chance of getting Ebola if you don't already have it by just going to the facility. And then 3, if you have Ebola virus disease, stay at home and self-isolate, your chance of dying is 70%. So that's the mortality rate without treatment. So given equal chances of having malaria or Ebola virus disease, your overall mortality risk for staying at home is 35% versus 40% for going to the treatment unit. So you would be acting in your rational self-interest by staying at home, since the suspect who is uninfected might become so nosocomially through ambulance transport with actual cases or unsafe triage at a treatment unit, and then not factoring in rational desires to die at home rather than in the queue in front of a far-off tent, rational fears you might not see your family again, rational responses to the pervasive messaging that Ebola has no cure, or the tragic irony that once admitted to an Ebola treatment unit that does not offer intravenous volume replacement, rational decision might be to deliberately infect yourself with malaria, because there's some evidence that shows that people co-infected with malaria actually have better outcomes than those that have Ebola alone. So therein lies the Ebola suspect's dilemma, at least according to the rational choice lens that refracts the world around us into binary options for our moral retinas. So now consider a special report by our good friends at the WHO. In it, the authors rightly, if not tautologically, suggest that shortening the delay to isolation of Ebola virus disease suspects will lead to a quicker overall outbreak containment. Yet they fail to adequately discuss the reality that suspects will continue to be, quote unquote, unwilling to seek medical care. So people got blamed for not going to these treatment units and we'll get into that in the next part, when such care is non-existent. Indeed, our extensive interviews with survivors of Ebola virus disease and their families reveal, among a variety of reasons for Ebola treatment unit avoidance early in the outbreak, the common suggestion that international non-governmental organizations in future epidemics not be allowed to set up Ebola treatment units if they do not provide the standard of care. So here's a theme here, providing standard of care, at least as aggressive as you can be with the resources you have. Conversely, if Ebola suspects maximize their chances of survival by staying at home in the case above, they risk, according to the methodological individualist framing of a multitude of after-action reports, of which you'll hear one soon, being dubbed super spreaders, or even vectors, what they're called. If they actively flee from their village to another, they've been termed vectors. So such terminology perniciously diverts us from the structural determinants of Ebola virus transmission by positing bounded individuals and their unconstrained calculating agency, or its contralateral blinder, fear-related behavior. And they actually describe it as this in manuscripts about Ebola virus disease patients, that they acted based on fear-related behavior. And this term was originally made for lab rats in the 50s, so it's now resurfacing for humans. So we invented a word, or I invented a word called, instead of Ebola suspect, we will call them the Personal Protective Equipment Bereft Care Nexus, PPE Bereft Care Nexus. We find that more appropriate anthropologically and philosophically because it highlights the fact that Ebola is a caregiver's disease, thrives in underdeveloped and historically plundered regions, and that the use of terms like super spreader or vector factitiously implicate marginalized individuals as sources of outbreaks instead of lending analytical weight to how social forces become embodied as pathology. In the final analysis, however, the implication that there is a decision to be made, seek medical care or not, or a spreader to be found is merely a cognitive convention that has been imposed on the PPE bereft care nexus by Western philosophy. Such language is couched in rational choice models and other scientific paradigms, that is, technocratic ways of thinking which elevate formal rationality practiced in modern science to a quasi-divine faculty for isolating truth, without considering the plurality of roles that reason can take. These Platonic shadows on the wall also divert attention from outside the cave, where legacies of the transatlantic slave trade, colonialism, indirect rule, structural adjustment, and extractive foreign companies, the real super spreaders. You never remember WHO ever calling those things super spreaders, but this is the kind of things that we're getting at. Those shifts in vocabulary, I think, are going to be part and parcel of the way to address accountability that we're talking about here. And so I'll leave you to, you can read the author's, the letters to the editor and the author's reply in Lancet Global Health, since I think that took longer than I thought it would. All right, now for another after-action report. All right, here is a list on the WHO site of all the after-action reports until May of, what is it? Where's May 2016? Wow, okay. So yeah, there's more that aren't on here. So lots of after-action reports, mostly written by people that perform no action on the ground. And there's a lot more, because I'm involved in one from Wellcome Trust that hasn't even been published yet, and it's become absurd. So, all right. So here's a quote from, we'll just say the last name is Walsenorb. Looking from far above, from our high places of safety in African society, is easy to see all the crudity and the irrelevance of bureaucracy. But without its power and guidance, early man could not have mastered his practical difficulties as he has done, nor could man have advanced to the higher stages of civilization. So it's a tweak on a Malinowski quote, but it'll become more clear in the when you read the chapter. And I'll say beforehand that I just wrote this in the last few days, so don't blame my co-authors for its shortcomings. I had a lot more clinical work in Tanzania than I thought I was going to have over the past month. So, but when the chapter comes out, then blame goes to Paul and Salman if it has shortcomings, because they are the editors or senior authors. All right, so the executive summary of this after-action report. So the Ebola pandemic that began in 2013 exposed deep inadequacies in the international institutions responsible for protecting the public from far-reaching biosocial consequences of infectious disease outbreaks. The pandemic raised a crucial question. Why were the incidence and mortality associated with Ebola virus disease so high in West Africa as opposed to the rest of the world? So, about 70% mortality in West Africa. We'll get to a slide. 0% in American white clinicians repatriated to the US. So to address this question, Chinua Achebe posthumously commissioned a study of the pacification of the primitive tribes of Lake Geneva. So if you read Things Fall Apart at the end, you could read from that a request for such a report. And since the magical beliefs and practices of these tribes have rarely been studied ethnographically, it seemed desirable to investigate them as an example of the extremes to which human behavior can go. So based on off-the-veranda participant observation and in-depth interviews conducted in both Switzerland and Sierra Leone, so I actually have worked for the WHO and MSF and Partners in Health and all the tribes you will see described here. The following commissioned report, number 46 in a distinguished series from the World Health Organization, on tribal pacification presents our observations across 4 thematic areas. 1, the pacification of a bold social justice agenda in global health by cults of cost effectiveness, as we've been discussing, and bureaucratic iron cages. The pacification of therapeutic courage by the savage reliance on containment by isolation rituals, and the magical religious fetishizing of purpose-built Ebola treatment units. The pacification of global health ethic through uncivilized research programs lacking in clinical delivery platforms, and the pacification of rapid care delivery through tribal shunning of partnerships. So, second section is called the Iron Cage of Global Health. So after visiting some European archives, we discovered parchments scribed over a century ago by Rebu, and Inyanga. So Inyanga is Zulu for like a medicine person or diviner. So Rebu is from the chiefdom of Saxony. And in oracular fashion, he predicted that as societies become more efficient and rationally organized under the spirit of capitalism, humans would begin to find themselves trapped in a system based purely on technological efficiency and instrumental action. Sound familiar? He labeled this trap the Iron Cage and called its predominant inhabitants the Tarquarabs. Just read things backwards. So this divination has found its apotheosis in the OHW, a tribe of Tarquarabs and medicine persons dedicated to providing technical advice to improve the health of people they rarely, if ever, meet. And in anthropology, we call this a form of dumb barter. So dumb barter is where you exchange stuff with people that you never meet. So the Tarquarabs received numerous CSEs, which were cowrie shell equivalents, for their advice. So after 2 stints as participant observers at the OHW in Geneva, we were able to establish sufficient rapport to examine their relics and join their rituals. Yeah. What, 10 minutes left? Okay, yeah, I'll get that in 10 minutes. So OHW culture is predominantly characterized by an activity they call paper pushing. And they also spend many hours each day in front of luminous tablets through... He's always correcting me on my dialect is... I didn't quite get the linguistic training, even though he's on my committee, that I should have. So they spend many hours each day in front of luminous tablets through which they communicate with each other. So via a silicon-based cooler ring. So cooler ring is a famous thing in anthropology where basically gifts get circled ritually as a form of building community. So this is a silicon-based cooler ring, and the Tarquarabs circulate ephemeral objects they call liams. Emails. So liams are rarely held onto for long, but rather forwarded through a complex network where the mere act of such circulation substitutes for field labor. Indeed, the OHW was heavily criticized for not taking decisive field action at the time it confirmed the circulation of Ebola virus. And we have a bunch of references for that, so I won't go into it. As one informant put it, when thousands of people start bleeding out of their eyes and mouths, sometimes it's best to take a step back and see where it's all going. So the OHW tribe and their anthropologist mercenaries also played a role in promoting culturalist claims of causality regarding the genesis of the Ebola pandemic. This tribe has taken a blood oath with an anti-politics witch to convert all political economic phenomena into technical bits amendable to spirit mediation by social scientists and medicine persons. So this is kind of what I was talking about yesterday. Thus, we have heard the tribespersons chant, and this is an actual quote, the traditional burial practices played a major role in the spread of Ebola virus. You will never hear the OHW say, transnational relations of inequality played a major role in its spread. So that's kind of, I think, a paradigm shift we need to make. So one of the most vociferous OHW house societies, so that's like Levi Strauss, never mind, is a cult dedicated to the deity. Here's the culture's claims of causality. Here we go. I mean, so we got Nature saying cultural struggle to stamp out Ebola. Guinea government bans bat soup. Kissing corpses is helping spread Ebola in the Washington Post, etc. All right. So one of the most vociferous OHW house societies is a cult dedicated to the deity Tsak Senevitsev. We've heard about him earlier today. So we have an anthropologist who studies this deity right here. Over the years, this cult has opposed the treatment of multi-drug resistant tuberculosis in Peru. Okay, we heard a lot about that because the expense was too great for the tribespersons to bear. Similar arguments were made against introducing ARVs to Africans with HIV/AIDS. And despite their fealty to Tsak Senevitsev, both of those beliefs by people in the room have been debunked. So what happens?
The cholera vaccine, so as it will be relevant in the discussion.
That's a good example.
So it's not just prevention versus care, as Randy was trying to, but it's really, the soft cult. We disagree on how to pronounce it. Has also involved HPV vaccine for girls across Africa, cholera vaccine for Haitians. Sorry, I.
No, it's good. We'll add it. You'll add it. And so, based on our, participant observation, we identified 4 stages of OHW's acceptance of evidence. So they might be getting to the 4th stage for the predicament you presented earlier. First, they say, 1, this is worthless nonsense. 2, this is an interesting but perverse point of view. 3, this is true but quite unimportant. 4, we always said so. And that's pretty much and that's from Haldane from 63. But
also 5, we're already doing it.
So unfortunately, though, the inertia of these treatment taboos continues into contemporary pandemics. As discussed in the next section, the Tarquarabs' primeval fear of diverting money from preventive measures paradoxically result in the preventable deaths of an untold number of non-Tarquarabs. Section 3, the containment mystique. So since the colonial period in West Africa, the dominant logic for epidemic disease, including smallpox, malaria, and influenza containment, has been isolation, with little in the way of patient care. We have a good book coming out on that soon. You have a good book on that. Thus, it was not surprising in our fieldwork to see that many Ebola temples simply functioned to isolate sick patients while only offering oral rehydration. So even if you look at the CDC playbook for stopping Ebola outbreaks, find, respond, isolate, prevent, nothing about treatment. It's amazing. Despite ritual whaling by the FSM tribe, the international containment response did not begin in earnest until the OHW tribe sounded the magic chant in August 2014. Public health emergency of international concern. Public health emergency of international concern. As an extension of this containment-only fetish, one could posit high-income country biosecurity as the primary rationalization for this tardy aid. So this foraging for biosecurity, so the high-income countries can be thought of as foragers for biosecurity. Supports our claim, essentially, that Guinea, Sierra Leone, and Liberia were used by the hordes of the global north as a large West Africa Ebola holding unit. All right, 2 more sections. Savage rituals. So some of the most savage rituals we witnessed in the field were the research without clinical delivery rites. Akin to cannibalism, these rites sacrifice human lives to certain deities. In this case, a particularly monstrous cosmic being named Latipek Chimadaka. And this deity has been studied by Pierre Bourdieu in depth. So these rites were notably performed in the Kenema district, where tens of millions of US dollars were used by a university consortium for biodefense research, with very little earmarked for clinical care. We thus witnessed the most absurd and tragic of phenomena, that of a shiny, well-resourced laboratory next to a dilapidated, poorly resourced hospital. Despite the heroic efforts of OHW and Sierra Leonean medicine persons, many of the latter, including their patients, perished because of the lack of prioritization of clinical care. And this lack of clinical care delivery platform also engenders witchcraft. We observed a university research assistant, twice I caught him, surreptitiously entering Ebola temples to draw unauthorized blood samples for a rapid diagnostic test validation study. Essentially, universities that didn't have clinical delivery platform were sending their researchers over the fence without PPE to draw blood on positive patients so they could validate a test that they had intellectual property on and wanted to test quickly so they could sell it to the world. Actually, I think that they wanted to sell it to all the airports. Anyway, tribal fetishes. Tribes of Lake Geneva are obsessed with a deity they call, oh, there's our friend, I'm not talking about this. You want to tell us about your friend real quick?
The Lassa Award is the most famous Lassa Award, well, the only one in the world, and it's awarded by CDC, WHO, Harvard, Tulane, and NIAID, and the U.S. Defense Department.
Yes, and it was run by a man who died of Ebola.
On July 29, 2014.
Sheikh Kumar Khan.
Yes. And he was,
Who was supposed to spend his sabbatical here at Harvard last year.
And he was supposed to get an experimental dose of ZMapp, but OHW and FSM doctors decided that if it didn't work, there would be such a backlash on Western medicine that they couldn't face that reality. So they denied him potentially life-saving treatment.
OHW.
It was only FSM. It was not OHW, the clan.
They fought over it?
But he was in an FSM center, so they got to make the
Make the final decision? Okay, good.
And
Thank you for clarifying.
he, being an expert on hemorrhagic fevers, was not consulted. His opinion on the matter was not consulted.
And then they gave it a couple days later to Brantley, right? The ZMapp. They flew it to Liberia and gave it to a white guy. Two. Oh, yeah. And yeah. Yeah. So the tribes of Lake Geneva are obsessed with a deity they call Yefaretz Krawach Chalea, to the extent that they are blinded towards alliance with other tribes. For example, our Liberian Sierra Leonean informants who worked for their respective health ministries told us that one fiercely independent tribe in particular, FSM, was notoriously difficult to partner with in terms of shared agendas. This subservience to Yefaretz Krawach Chalea deity led to justifications of therapeutic nihilism, where clinicians in Ebola field treatment sick units So I'm calling these ET SICUs because there was no treatment in them. And I worked at this one, so I worked. Oh yeah. Healthcare worker safety, the god of healthcare worker safety. So
Is it bad to interrupt just to say one thing? You know, since you're talking about accountability and that's a theme, if you know, again, we need the historians here since they have worked so much on this in American medicine and elsewhere in colonial medicine. If you believe that there is a traditional social contract between professional care providers, nurses, doctors, and patients, it's fetishized as put the patient first. In this instance, and in all documented outbreaks that we've studied,
in this instance, thank you, and in all documented, all the epidemics since 1976 that we studied, and the same holds for Marburg, not in Germany, where the first epidemic was documented because there was a capacity to identify the pathogen that had been imported in monkeys for polio vaccine production. In each one of them, there's been an inversion of the standard social contract, so that if there are three parts to it, put the patient first, you know, the caregivers second, and stop containment. It's just that this is an inversion, and even without making a moral comment, which clearly we're not shy to do, the inversion was explicit and repeated. And Sinead and Oliver Johnson have surely written about this in their book as well. We were, you know, you just got, you know, hit over the head with it, that the priority is not to reduce case fatality rate, which is quite unusual, right? Because, you know, it's I've never seen it in the Brigham, you know, or you don't see it in Stanford, you don't see it in university hospitals in Europe. But it was quite explicit. And I'm sorry to interrupt the flow. It's just that, you know, if you weren't there, it wasn't subtle. I think it's fair to say it wasn't subtle, but it's certainly. I don't think anybody in this room would ever be on the receiving end of that inversion, but it was very familiar in West Africa, as Randy noted yesterday.
And we'll have more time to tease this out in the discussion, which Sinead is going to lead. Only 2 more pages. Okay. So yeah, here's the Kailaun FSM Treatment Center. I worked there. We weren't putting in IVs, so.
Can you elaborate on that for 1 second, the importance of IV fluids, so everyone in the room can
Sure.
understand?
You know, people dying from Ebola, usually dying from shock, which is, you know, they're either putting so much fluid out via vomiting or diarrhea, or they're having like internal leakage, that the way to resuscitate them is by giving them fluids. And if someone's really vomiting, you can't give them fluids to drink, so you got to put it through an IV. And so, you know, this 0% that was achieved in the U.S., yeah, we have dialysis, yeah, we have ventilators, but, you know, you could throw out there that with good, hot, aggressive care with minus a vent and dialysis, you could get it down to 30%.
Can I just add something, because it's important. And Salman, thank you for reminding us that none of this is straightforward. It's also highly contested. What we're talking about is, first of all, this is a disease that is really not acute like we think of it. It goes on for usually a month, and its sequelae can go on for over years, including persistence of viable virus in the testes, breast, brain, eyes. Okay, that's one thing that's important to know. It's again not dissimilar from things we've seen with other infectious pathogens that get reclassified from acute to chronic illnesses. But the hard part about this is that even if you agree that the classic Ebola hemorrhagic syndrome, which involves precisely the kind of fluid leak that Jean mentioned, if that's a classic syndrome, that doesn't mean it's the only syndrome. And what we're talking about in this paper and others is that many patients in this epidemic and in previous ones lost up to 10 liters of fluid a day from diarrhea, vomiting, what are called insensate losses in hot climates, and fever. So how would we know that? we didn't learn it and we could see it in front of us, but to measure it, that was measured in the expatriates who were repatriated to Europe and the Americas. And we have friends and patients who are well documented to have lost 10 liters a day. And as Gene said, you know, if you have children, he didn't say this, but I'm going to add it. If you have children and they're not vomiting, it's hard to get them to drink a liter of Pedialyte, right? So to have an argument like this about that subset of patients who are clearly incapable of being resuscitated by oral solutions of any kind, we wanted to get at the heart of this debate, not to win an argument, but to ask about accountability. I mean, because really no one here or no one's clinician here would argue that it would be possible to replace 10 liters of electrolyte-rich effluent by drinking oral rehydration when you're vomiting. Is that fair? Is that what you're getting at, Salman, that kind of explanation?
I just wanted everyone to be clear on that, and if you can elaborate one more thing, unless, Gene, you're going to. Was there an indication, was there a signal that went up not to give IV fluids to people?
A signal?
Repeated, daily, policy level, in print. Yes, please, Sinead.
I mean, I think it's important to note that this was at an organizational level, right? So there were no WHO guidelines that said don't give IV. But, you know, MSF, for example, I mean, MSF never actually had a policy not to give IV, but they had like in any kind of, you know, general written way, but there were many occasions in different of their ETUs in the 3 countries where in practice, you know, as Paul was saying, you know, on a day-to-day basis, they said that they weren't going to give IV because, and I think this is also important for people to understand, they said it's too dangerous for our staff to have that level of contact with the patient where, you know, a lot of our staff are not very well trained or experienced, and, you know, they're then sort of putting themselves at more risk by, you know, so it's not a black and white argument. I mean, healthcare safety obviously is very important, right? But I think that the point that's being made is that in the Ebola outbreak, we took it to really a whole nother level. You know, we had a lot of paranoia, and MSF, you know, certainly informally, some staff have acknowledged to me that, you know, we should have, there were times where we definitely couldn't have done the IV, like Monrovia in August, absolutely no way. We had 1 minute per patient, it was impossible. But there were times when we could have gone back to doing it in terms of our resources, but we didn't. And that is really, I think, the point that we're all making, is that because the patient care wasn't prioritized enough, those decisions didn't get changed even when the resources allowed in with some organizations.
Yeah, I mean, in the short time I worked at the Kailaun site, we weren't allowed to put them at all. Essentially, the paramount chief in Belgium said it's too unsafe. And so I'll just finish. I won't read the rest of it. You see where I'm going with this. You can read the draft online. But to answer this question of, you know, was this focus on healthcare worker safety, you know, evidence-based? So some quick stats. You know, I have the internal data for both organizations. And so the FSM tribe essentially had 1 staff fatality per 354 patients treated. And that's, you know, not putting in IVs most of the time. And then a different tribe, HIP, had 1 staff fatality per 630 patients treated. So it's actually had double the rate of staph infections, and they weren't even putting in IVs. So there's something else. Yeah. Much in most patients, you know, some don't need them if they're.
I hope it doesn't, you know, when Sinead says not black and white, it's also not these 2 tribes.
That data on, right?
And although I do think that I mean, the internal critique
Of the other tribe, and the critique that I would make of our tribe are much more devastating than one Gene's making, right? And we have written, you know, circulated and Gene was in one of those units. So it wasn't, it wasn't just informal, right? It was policy that was disseminated.
But what I'm saying is, it wasn't like WHO,
Well, let me just say that, and again, this is going into the discussion in private discussions, but not that private, with WHO personnel. The heritage, again, back to Randy's presentation, the heritage of smallpox eradication, which is about ring vaccination, isolation, quarantine, and sometimes even raising villages, and the materials within them. The sanitarians of the late 19th century, early 20th century lead to the smallpox tribe, and you'll fix the language. And, fortunately, they're still with us. Some of them are friends of ours. And, bringing up the idea that one of the problems about refusal to go to an Ebola treatment, and one of them was, of course, because people were being told contradictory things, go to the hospital, don't go to the hospital. But another one is that they had pretty reasonable assessments of their chances in that kind of setting. And bringing up the idea that improving the quality of care in admittedly horrible conditions would make it easier to bring them into isolation was received as an altogether novel idea by some of these people who are friends of mine, ours, who have MDs after their names, but are not clinicians. They're disease control experts. So, and I know there's a lot of passion behind this, and part of it is because it's just going to happen again and again, but it's not going to happen here, because all of the things that we're describing, none of those things happen here. The super spreaders of Ebola hysteria, as opposed to Ebola, were Twitter, social media, Donald Trump, etc., all abundantly documented by CNN and by historians and sociologists who are already writing about this. And forgive me, please, for adding, and Gene, I hope I didn't interrupt your.
Not at all. Yeah, the reason I use those two tribes because that's the data I have, and I want to make the point that for future outbreaks, that there were doctors at FSM that were crying each night because they weren't allowed to perform their duty, so that this doesn't happen again. And then I'll part real quick. Speaking of the smallpox stuff, I was on an Ebola panel with the late great D.A. Henderson, and he says to me, "Gene, why are you fooling around in West Africa? I used to just go grab somebody and force them to take the vaccine, and that's how you stop an epidemic." And I was like, "All right, cool. I'll go try that."